Okay, so we are gonna continue on MCQs, and like we said the first session, our aim here is not to copy paste and review exact MCQs بمقدار ما إنه we just want to tease out the main cardiac ideas, which is gonna repeat in all exams. Okay, just a warmer. Which of the following proverb idioms has correct scientific underpinning? Yeah, that depends on how you understand this stem. يعني which of the following proverb or idioms has correct scientific underpinning? He, she has big heart, wear your heart on your sleeve, follow your heart, learn off by heart, break my heart. Any guess? Any guess? طبعا if you say إنه has a big heart, the way is meant literally is so different than scientifically. Big heart is a diseased heart, but big heart means kind-hearted. It's so different than each other. Wear your heart on your sleeve to be courageous. It's nonsensically, scientifically. Follow your heart, learn by heart. But break your heart, now we have it, right? We have broken heart syndrome scientifically, and we have it literally, yes? Okay, so 72-year-old man admitted with acute coronary syndrome and successful PCI to LAD. Done. His blood pressure 125/70. Hemoglobin A1C is 7.2. LDL is 2.1. He's already taking and reasonably adherent to atorvastatin 40 milligram. What is your next step with regard to his lipid management? He is well controlled and no additional therapy is needed. He needs up titration of atorvastatin to 80. He should be started on evolocumab. Ezetimibe is indicated as add-on with 6 months check on lipid profile. Ezetimibe is indicated as add-on with less than 6 month follow-up on lipid profile. 6 weeks, sorry, 6 weeks. So what do you think? طبعا lipid management now is so important topic, okay? And we know now it is a stepwise approach we should all know about, especially for very high risk patient like this patient. Yes, very high risk patient like this patient. Yes, the patient who already have atherosclerosis, like PCI and all of that, they are considered very high risk patients. So the target for this patient is 1.4, less than 1.4, okay? Millimole per liter. So now we have it 2.1.
Should
So
up
this,
I
titrate
think B.
atorvastatin to 80
uh-huh,
milligram.
to 80. Uh-huh. Any other opinions?
I think any patient with ACS should receive high potency statin, regardless of the baseline lipid.
يعني انت you agree with up titration to 80?
Yeah.
Okay. طيب. Let's go for the guidelines, which actually has witnessed a recent update maybe a few months ago. But here, it's recommended that high dose statin is initiated or continued as early as possible. By the way, 40 milligram atorvastatin is considered high dose. And it is recommended to achieve LDL less than 1.4, okay, for these patients. If the LDL goal is not achieved despite maximally tolerated dose, after 4 to 6 weeks, the addition of ezetimibe is recommended. Okay, now if the LDL is not achieved despite maximally tolerated dose statin therapy and ezetimibe after 4 to 6 weeks, the addition of PCSK9 inhibitor is recommended, like evolocumab. Okay, but I think we are already here. We have this patient on maximum dose, and we go just for ezetimibe next, and we see him in less than 6 weeks. If it's still more than 1.4, we add evolocumab. Okay. Now the dose of atorvastatin 80, nobody push statin that much anymore. Yes. يعني hierarchical management of lipid is atorvastatin 40, if not controlled, ezetimibe 10, if not controlled, evolocumab 140 weekly, bi-monthly. اوكي تمام يا شباب. كل الحاجات دي should be achieved in less than 2 months، لانه انت you follow the patient مع الدوزة الاولى بتاعت الستاتين وتديه 1 month، then you add ezetimibe تديه 1 month، then you add evolocumab. قد يكون كنترولد على الستاتين الون، قد يكون كنترول على الستاتين ezetimibe، قد يكون محتاج triple therapy which is atorvastatin, ezetimibe and evolocumab. You never know. مع انه في بعض الالجوريزمات باي ذا واي بيقول لك انه اصلا اذا انت بديت ب LDL 3 او حتى 2 point something، انت your maximum achievement of atorvastatin is 60% reduction. So if you take 60%, he will not come to the target. Now add ezetimibe, it's gonna decrease it overall 70, 80% from the baseline, so he will not go into the target. So you can guess which patient can go to the target with atorva and ezetimibe, and you can initiate triple therapy right from the outset if you feel that ezetimibe and statin will not bring the LDL to the target. ولكن this is not in the guidelines, though there are so algorithms out there which work this way. يعني they decide how to start evolocumab based on the baseline LDL. ولكن the guidelines ask us to go stepwise. Statin, ezetimibe, evolocumab. Okay. So the answer here is E. Just a moment. Which of the following results in decreased pulmonary vascularity on the chest X-ray? Okay. يعني pulmonary oligemia. ASD with patent ductus arteriosus, ASD with restrictive VSD, ASD with tricuspid atresia and restrictive VSD, ASD with partial anomalous pulmonary venous drainage.
سي.
Yes. See, exactly. Yep. لأنه كل البقية هذولا ASD with patent ductus arteriosus brings more blood to the lungs. ASD brings more blood to the lungs. ASD with partial anomalous, two sources of increased venous retain to the right side, therefore increase blood to the lungs. It's only this ASD with tricuspid atresia. Because if you have, sorry, who answered this question?
مهند.
Muhammad, طيب, can you explain why C the right answer here?
I think tricuspid atresia. There is a little blood will go to the lung.
Exactly.
Or the
And what about the ASD, طيب?
ASD, there is much blood will go to the lung. It will be a plethoric lung.
اتخيل حتى ال ASD in context of tricuspid atresia is gonna act paradoxically. It's gonna act right left instead of left right flow. لأنه إذا أنت عندك ال tricuspid valve like this وعندك ASD هنا. طيب عندك هنا very high pressure because of tricuspid atresia. The flow is gonna go through the ASD right left. يبقى رغم انه عندك ASD لكن is contributing to the oligemia, lung oligemia because of the tricuspid atresia. Okay. هنا this is gonna lead to severe oligemic lung field. Okay. ممتاز. Which of the following terminology defines a viable myocardium? Stunning, hibernation, stunning and hibernation, remodeling, preserved thickness.
Stunning and hibernation.
See?
Stunning and hibernation. This one. Stunning and hibernation. What about someone who chooses hibernation?
يا بص، هي الهايبرنيتنج مايوكارديوم دي مش الريسبونس للكرونيك اسكيميا، بتكون الاكيود ستاننج، والكرونيك بتكون هايبرنيتنج. حتى بتتعرف بالفيتامين ستريس ايكو، بتكون باي موديل ريسبونس، بتكون اي كاينتيك باللو دوز، تبقى اي كاينتيك او هايبوكاينتيك. عشان تبقى كاينتيك في الماكسيمم دوز بترجع لاي كاينتيك تاني.
Yes. And then hibernation, you are right. Biphasic response. And what is stunning?
Stunning, this is the acute response of myocardium to ischemia.
Okay. So it's viable, huh?
Yes,
What is
both of them, I think they are
أيوة.
viable.
Strictly speaking, when we talk about viable myocardium, is the myocardium, and we check for viability, we are actually checking for hibernation. لما تقول لي myocardial viability testing, معناته you are testing if the myocardium is hibernating or dead or fibrotic, I mean. Okay? لكن السؤال قال viable myocardium. يعني not viability بالطريقة اللي احنا فاهمينها. Which one of these is viable myocardium? Okay? يعني لما يكون عندك stunning hibernation, both are viable myocardium, therefore I'm going to choose this one. Okay? Remodeling is a different concept. Preserve thickness is a different concept. يعني مثلا الآن في الإيكو، الناس لما تقرأ الإيكو يقول لك the thickness is preserved. بالتالي it's viable myocardium. No, that's not right. يعني preserved thickness is not a definite answer to viability. يعني الميوكارديوم if it is a thickness is preserved, it may be viable and it may be non-viable. You can pass a final verdict. لكن لو كان thinned out, thinning out, هو diastolic thickness less than 0.65 in diastole, this is non-viable almost for sure. يبقى thinning out is more meaningful in terms of non-viability than the preserved thickness, which might be viable and might be non-viable. Okay? يبقى يا شباب, whenever you read an echo and there is preserved thickness, don't jump إنه والله خلاص we are assured إنه the myocardium is viable. No, it can still be non-viable برغم أنه preserve thickness. Okay? يبقى الترمينولوجي هنا المهم جدا اللي you should all know about هو stunned myocardium and hibernating myocardium. stunned myocardium زي ما انتوا قلتوا هو is a result of acute ischemia after reperfusion. يعني انت بيكون عندك مثلا myocardial that is under ischemic influence, then you restore circulation or you restore the perfusion. شنو اللي بيحصل؟ It remains hypokinetic or akinetic. يعني معنى ذلك there is a mismatch between the function and the perfusion. Okay? يعني انت أعدت البرفيوجن لكن الfunctions is gonna lag behind. Is not immediate bounce back. Okay? This lag of time between restoring the perfusion and restoring the contractility is called the stunned myocardium. وبتحصل بعد الكابج بعد الريفاسكولاريزيشن. It takes few weeks to a month or two ويرجع الميوكارديوم مرة تانية with normal contractility. Now hibernating myocardium is a myocardium in which you have akinesis and you did not do yet PCI ولا أي حاجة. أنت you are just seeing a lack of contractility in segments and you know that it is ischemic myocardium. So this akinetic part, is it viable or not viable? Is it worthy of revascularization or not? That depends on viability testing. So if you do viability testing and you find that part is viable, therefore it's called hibernating myocardium. So what's the opposite of hibernating myocardium? Is scarred myocardium or non-viable myocardium. يبقى كلمة hibernating معناتها it is not contracting ولكنه it is alive. So there is a big chance of inner contractility is going to come back after revascularization. Okay. طيب طبعا يا شباب انتم متذكرين في حد سمع بريفايفل ترايل؟ ريفايفل
Yes.
يعني any idea about it يا مهند؟
I think recent trial قبل سنتين أو ثلاثة مش كده؟ Revive.
Yes. Yes.
Check for viability before BCI. They check for viability and do BCI, but I think the trial was negative.
Yeah.
Test for viability did not improve the outcome.
Compared to?
I think medical therapy.
Yes. They found no difference between medical therapy and PCI with medical therapy in hibernating myocardium. This is cast doubt upon the utility of PCI for hibernating myocardium. And it seemed that PCI is the best kind of therapy for, if it is primary PCI for acute coronary syndrome, for STEMI and stuff like that. Looking for chronically hibernating myocardium in Revive, حتى في ischemia trial, there was doubt about how useful PCI is in these patients. Compared to medical therapy, there was no difference. Okay? And maybe the guidelines are going to change accordingly. طيب, a 65-year-old woman recently admitted with shortness of pulse class 3 and high renal profile after a long period of chronic kidney disease. She was initiated on dialysis through a jugular venous catheter. Her hemoglobin is 8, creatinine is 750, and the pro-PMP is 6,500. The nephrologist consulted you regarding the high level of pro-PNP and the echo is requested and revealed normal LV and RV systolic function. What is the interpretation and or recommendation you will give regarding the level of pro-PNP? So you are going to order serial monitor of pro-PMB level, or you have to rule out ischemia, or the level is high due to renal failure and will decrease with dialysis. The level as given is a lab error because it does not correspond to normal LV function. The echo is erroneous in the diagnosis of normal LV systolic function. So what do you think?
Ischemia has to be ruled out.
Okay.
This could be myocardial injury with anemia, but still we need to rule out ischemia by
Okay.
symptoms and by ECG and yes.
Okay. Okay. طيب. Ruling out ischemia. Any other opinion?
C.
C. طيب يا مهند, you have chosen C. Can you defend your position?
I think this is very high pro BNB, but in the context of normal echo, I think it is due to the renal problem. Ischemia, if there is acute ischemia large enough to cause this large number of BNB, it should be some systolic or diastolic dysfunction.
Yes. Okay. Good idea. And I agree with you. The right answer is C, though B is not bad answer, but the best answer is C. And that is why. Look here. The patient is admitted with shortness of breath class 3 and high renal profile after a long period of chronic kidney disease. So it seems like acute on top of chronic. Okay. This patient has undergone dialysis, and the pro-PMB comes down to 1,200, something like that. And over time, it decreases to 600, 400, stuff like that. So we know that congestion, whatever the etiology of is a cause of elevated pro-PMB to a high figure like in thousands, okay? So ruling out ischemia is kind of jumping to conclusion. Pro-PMB might always be related to ischemia. Not necessarily. بالذات إنه البيشنت مثلا has no symptoms clearly of ischemia. And this shortness of breath coincides so closely with this acute deterioration of the kidney function. حتى لو الtroponin is elevated, might also be for the same reason. So we initiate dialysis and then we follow the patient, and the pro-PNB is going to come down. Now, if pro-PNB comes staggering high up and there are some different symptoms, we might act accordingly. Like in the initial response to high pro-PNB is to clinically contextualize it. Can it be contextualized clinically? Yes, it can be within this acute deterioration of kidney function on a patient of chronic kidney disease. Okay, so that's enough explanation. You don't have to go any further. Okay, so we're going to choose C as the best answer for this time being, and we are going to follow the patient. If the scenario changes, we are going to act accordingly. Okay. Which of the following is a phenotype of chronic coronary syndrome? Phenotype. So we know that we have a couple of phenotypes of chronic coronary syndrome. Which one of them is here? Angina after recent revascularization, angina increasing in frequency and duration, angina after 6 months of revascularization, asymptomatic patient with coronary artery disease in cardiac CT, asymptomatic patient with elevated troponin.
B.
B. B.
Asymptomatic patient with coronary artery disease in cardiac CT.
In cardiac CT. Okay, so D. You all agree with that? These are the phenotypes. Okay, we have stable angina, which we all know. New onset heart failure with suspected coronary artery disease. Stabilized symptoms 1 year after acute coronary syndrome or recent revascularization. Patients more than 1 year after initial diagnosis or revascularization. Angina suspected to be vasospastic or microvascular. Asymptomatic with coronary artery disease on screening. These are the 5 phenotypes of chronic coronary syndrome. If we go back, the right answer is going to be D. Yeah, angina after 6 months, no, it's after 1 year. Angina increasing in frequency and duration, this is unstable angina. Angina after recent revascularization has to be defined لأنه نحن عندنا revascularization after 1 year. Okay, not recent. Okay, asymptomatic patient with elevated troponin, this falls in a different category. تماما. Okay, so asymptomatic patient with coronary artery disease in screening, whatever the screening is, MPI, cardiac CT, coronary angiogram, yes, this is considered chronic coronary syndrome. Which of the following describe vulnerable plaque? طبعا the concept of vulnerable plaque is increasingly recognized, and there are so many questions about vulnerable plaque because it's so important we know how we diagnose vulnerable plaque based on the technology we have لأنه it's the precursor of acute coronary syndrome. صحيح? But it's not only the size of the plaque, but more importantly, the vulnerability elements. That's why we have to know about it. So which one is vulnerable plaque? Thick fibrous cap, large sheets of calcification, positive remodeling of the artery, more than 80% luminal narrowing, high attenuation plaque in cardiac CT.
I think positive remodeling. C.
Positive remodeling. C. Good. I think that's the right thing. Okay. طيب, can you change this one to be vulnerable?
Thin.
Can you change this one to be vulnerable?
Instead of thick, I think thin.
Very good.
Thin
Very good.
fibrous plaque.
Can you change this one to be vulnerable?
Low attenuation.
Yes, exactly. Exactly. So these are the features of the vulnerable plaque, which are here. You see, the positive remodeling is 1. Yes, when the diameter of the artery at the site of the atheroma is bigger than the baseline. So this is called extrinsic remodeling. Okay. The other thing is low attenuation. Low attenuation. Small speckles of calcification, not large sheets of calcification. And the heterogeneity, which is called napkin ring size, which indicates thin fibrous, and big fatty core. Yes, these are the features of vulnerable plaque by cardiac CT. So far, the only way of assessing vulnerability is by cardiac CT. Yani we can do it by MRI, we can do it by MPI, we can do it by coronary angiogram to some extent, okay? A CT is amazing technology to reveal الcomponents دي كلها, and you study the vessel and you do the vessel analysis in all these features, so you know exactly how the vulnerability is like, okay? In terms of thin fibrous cap, big lipid core, speckles of calcification, extrinsic remodeling, and low attenuation. Okay, so these are the vulnerability metrics. Okay, شباب. And I think the low attenuation is taken as less than 30 Hounsfield unit. طبعا by cardiac CT they know the Hounsfield unit of each part, so they put it here and I see how much Hounsfield unit. The darker it is, the more darker it is, the more low attenuation it is. So the cutoff value is less than 30, is less than 30. And remember, spotty calcification in comparison to large sheets of calcification. Okay. معلش شباب, سامعين صوتي؟ الصوت مسموع؟
واضح يا بص.
Okay, ممتاز. Which of the following ECG samples is most specific for myocardial ischemia? A, B, C, or D?
B.
Yeah.
B, down sloping.
B.
The second one is horizontal.
Okay, very good. I agree with you. This one is the first one, down sloping. Then this one, and last, the up sloping one. The most specific is this one, the down sloping one. Okay, good. So these are the morphology. Probably we have spoken about this before. The down sloping is the most specific, followed by the horizontal. And we know that also the T waves of hyperkalemia looks like this, symmetrical, narrow-based and pointed, while in hyperacute, it is symmetrical but broad. It's broad-based, okay? And of course, the asymmetrical, which we call early repolarization, is like this, okay? This complication is the one you see in here is sometimes طبعا MCQs we can write the description of what you see here, and we can also give you the diagnosis إنه في مثلا VSR, okay? And then we ask you, or we keep the images here, يبقى it is like double questions in one, okay? So this is like double questions in one, so you have to realize what this in and then you answer this one. So this complication is associated with soft murmur. It occurs 3 to 4 weeks after onset of MI. It does not occur with non-STEMI. Earlier surgery is associated with high success rate. Intra-aortic balloon pump is vital temporary hemodynamic support. في خط blue هنا ده عامل لنا contamination. Do you see it? This blue line here? I don't know from where
Yes.
it comes. From where it comes, this blue line. All of them. Strange والله. Okay, so what do you think?
Intra-aortic
Early
balloon pump is vital.
Intra-aortic balloon pump is vital.
Surgery. Early surgery.
Early surgery. اوكي طبعا احنا we all agree انه this is VSR right صح it's not VSD صحيح صحيح
Yes.
شباب
Yes.
ممتاز
Rupture.
it's ruptured yes so a murmur is soft or loud
Loud, harsh and loud.
yes unusual associated حتى with thrill in contrast to papillary muscle rupture leading to severe MR, the MR tends to be soft. المرمر حقه tends to be soft. Okay, and this is important distinction between the two. VSR is expressed clinically, يعني أو it expresses itself clinically more obviously than the MR complicating MI. لأنه المرمر is loud with thrill, هناك المرمر is quiet. Now, 3 to 4 weeks, can you correct this one?
Days or up to week earlier complication. Okay.
Exactly. And
Fair
usually
area.
mechanical complication in the first week of MI. Okay. Can it occur with non-STEMI? Yes, it can. It can. It's more common with non-STEMI or with STEMI, like it also can occur with non-STEMI. Now, early surgery associated with high success rate, unfortunately, طبعا, the only way or the best course of action is early surgery, لكن the success rate is not high. Okay, even in good centers, success rate is not high, and that is so conceivable. ليه؟ لأنه أنت if you want to patch this one here, الباتش is difficult. ليش؟ لأنه أنت when you wherever you put your patch, you really have to deal with some necrotic tissue here and here. That's why sometimes they put the patch so big as to from هنا لهنا. They look for whatever viable عشان to hold the stitches بتاعاتهم في الباتش. Okay? It's not an easy surgery at all, and the success rate is not high. Okay? فموست importantly إنه إذا البيشنت بالذات عنده hemodynamic compromise, which is most likely to have, to temporize the patient with intra-aortic balloon pump. Okay, so the right answer here is intra-aortic balloon pump. Okay, we have gone through this one before, but for a reminder, 70-year-old male presented with fever, positive culture, seizure due to bleeding mycotic aneurysm, and this echo. In the MCQs, we can describe the echo like sometimes we take the videos and we say, the left atrium is dilated, severely dilated. The valve is thick and fibrotic, and there is severe MR and no vegetation. No vegetation. Okay. Or we give you the videos as they are here, and you see that the valve is not healthy. The left atrium is dilated. There is severe MR. And there is probably prolapse of the anterior leaflet, yes, leading to posteriorly directed jet of MR. So here the question is, the patient has definite infective endocarditis because the clinical and imaging data showed 1 major and 3 minor, or possible infective endocarditis because 1 major and 2 minor. Severe MR in echo is considered major criteria. T showed mitral valve vegetation. A history of dental procedure is a minor criteria. So what do you think? Positive culture, fever, seizure, bleeding mycotic aneurysm, and this echo.
A 1 major and 3 minor. The major is the vegetation, and minor fever, mycotic aneurysm, and predisposing valve.
Very good, Yaiman. The only amendment هو إنه ما في
البوزيتيف
vegetation لكن في
كلتشر
positive
بس
culture.
ما
Yes.
موضحة.
ها
typical
Yeah.
organism إذا typical
Typical.
كده
Yes.
تكبر تو
Typical.
major.
Typical organism. Yes. Okay.
Okay.
Here لما يكتب لك positive culture without labeling معناتها he meant typical one لكن sometimes they give you the name of the organism. So we have one here, one major, like Iman said. This is one major. هنا this is one minor, fever. This is one minor, mycotic aneurysm. And what we are seeing here is one minor, which is predisposition. The valve is predisposed to infective endocarditis. طبعا واحد ممكن يقول لي يعني الفالف دي maybe is affected by the infective endocarditis. يقول لك no, it's unlikely لانه يعني this kind of severe fibrosis and thickening or left atrial dilatation is kind of a chronic condition. But most likely the patient had pre-existing valve disease. On top of that, he gets the infective endocarditis. Okay, so let's remember يا شباب إنه predisposition is one predisposing factor. This one is not minor criteria. This one is not any longer. It was, by the way, سابقا. It's considered one of the major criteria, but not anymore. Okay, so the right answer is this one. Okay. Right. Just a moment, يا شباب. I will answer this phone. Okay, so we are back. Sorry for the delay. So remember يا شباب guidelines 2023 are here. Okay. إنه positive culture and imaging positive for infective endocarditis. Now the minor criteria are predisposing conditions: fever, embolic, immunologic, microbiological evidence short of major. And if we have two major, that's definite. If we have one major and three minor, is definite. Or if we have five minor, is definite. So the echo can provide us with major criteria like vegetation, abscess, perforation, aneurysm, and stuff like that, the one we know and discussed before. But echo can also give us two minor, which is two minors الأساسيات اللي بدينا لهم الإيكو هم إيش؟ The predisposition، يعني إذا البيشنت اللي لقيناه عنده bicuspid aortic valve this is predisposition. Rheumatic mitral valve this is predisposition. Yeah? Yeah? So predisposition is one. And what other minor criteria the echo provides? This one. How come mycotic aneurysm؟ لأنه هنا these are the mycotic aneurysm. By the way, the typical site of a mycotic aneurysm is in the proximal part of the ascending aorta. يعني هنا after the sinotubular junction يحصل لك saccular bulging في المكان ده. طبعا ممكن يحصل في البرين، ممكن يحصل anywhere by the way، لكن the typical location is here. So we can see it in echo. We can see mycotic aneurysm here, and this is going to be also one minor criteria. And the predisposition is the second minor criteria. Okay? Good. In acute AR, which of the following statement is true? It can be a result of blunt chest trauma, can be a result of acute MI, associated with wide pulse pressure, associated with dilated LV, water hammer pulse is invariably present. Mhm. يا شباب.
A
A.
can be result from chest trauma.
Okay, A. Is it by exclusion? It's the right
Because
answer, by the way. You're
I
right.
know it is caused, one of the causes, others are dissection and infective endocarditis, but also by exclusion also is true.
Yes, yes. طيب, if we go by exclusion, a result of acute MI, can AR be a result of acute MI?
I know that MR.
Yes. Uh, acute AR and wide pulse pressure.
This is the chronic one.
Exactly. Acute AR and dilated LV.
Also same idea.
Exactly. Water hammer pulse and acute AR.
Also.
Also, and also it's more of a sign of elderly. يعني حتى في اليانج it might not be. حتى مع الكرونيك AR ممكن ما to appear. Okay? Yes, you are right. It can be a result of blunt chest trauma. Which of the following is the main cause of acute coil syndrome? Atheromatous plaque rupture is cytothrombosis, spontaneous coronary artery dissection, embolization from aortic valve, or root calcification, all of the above.
All of the above.
Okay. All of the above. All of the above is not wrong. ولكن if
A.
you If you
A.
exactly A. If you focus on the stem one more time, the question is not about the causes, but the main cause. Okay, so the main cause is this one here. Okay, very really we have to focus on the stem. Okay, good. Which of the following represent irreversible cardiomyopathy? Ischemic cardiomyopathy with thinning out and aneurysmal apex, tachycardia-induced cardiomyopathy, COVID-related cardiomyopathy, stress-induced cardiomyopathy, chemotherapy-induced cardiomyopathy.
A.
A. Exactly. Now, the way it looks here, remember preserved thickness is not meaningful, can be viable, cannot be viable, or may not be viable. Like in thinning out, especially if it is less than 0.6 centimeter in diastole, it's non-viable. Okay, so the first description is of a non-viable myocardium, which is irreversible cardiomyopathy. This one. Okay, the rest of these are potentially reversible cardiomyopathies. Which of the following are the current repertoire of non-invasive testing for ischemia? Exercise ECG, Holter, stress echo, PET, and cardiac CT. CMR, Holter, cardiac markers, and SPECT. PET, SPECT, cardiac CT, exercise ECG, stress echo. CMR, cardiac CT, SPECT, and stress echo.
D.
B. B or D?
D.
B. B. Any other opinion?
D. D. D.
D, you said D, okay. D. Okay. Okay. طيب, I see that the one with halter inside is out, صح؟ لأنه by the way, we can also check ischemia by halter. لكن halter is not for ischemia, right? By and large,
For.
it's not for ischemia. And cardiac markers is also not non-invasive testing for ischemia.
Also.
So we are left with C and D. طيب, no, why not C?
Cardiac MR.
Cardiac MRI can be used for ischemia assessment.
Yes.
Yes.
Yeah.
لكن I mean, why C is not right? There is one thing that makes C wrong. This one.
ECG. External ECG.
Yes. Exercise ECG is no longer non-invasive testing for ischemia. Alone. As a standalone. It can be part of imaging, testing, it's well and good. But standalone exercise ECG, because it lacks sensitivity and specificity, so it's no longer a standalone testing for non-invasive, non-invasive testing for ischemia, okay? So let's remember, we have cardiac MRI, we have cardiac CT, we have SPECT, we have PET, and we have stress echo. So in total, we have 1, 2, 3, 4, 5. 5 non-invasive testing for ischemia, okay? Again here, this is similar to the MCQs we have discussed before. A 70-year-old patient is admitted to intensive care with pneumonia, which necessitated intubation. He also went hypotension and started on inotropic support. During the course of hospitalization, he developed acute renal injury and hooked on CRRT. And this is his chest X-ray. Okay, as you see. So his troponin was 0.56, then 0.9, then 1.2 serially, 8 hours apart. And the ProPNB 3,500. So which statement is true? The rising troponin is consistent with acute coronary syndrome. The elevated ProPNB is due to ischemic cardiomyopathy. Cardiomegaly in the chest X-ray and the elevated ProPNB indicate severe LV systolic dysfunction. The rising troponin and ProPNB may be due to sepsis and metabolic derangement.
D.
B.
D.
Sorry, D. Okay, D. And this is the right answer, by the way, D. Although it's tempting to choose this one, لأنه you see how rising the troponin is? Yeah. This argues against نحن دايما we know okay إنه إذا أنت عندك elevated troponin due to renal impairment, it tends to be of flat trend. Yeah. ما فيه increments that genuine increments. لكن now we have genuine increments in the level of troponin serially. لكن the question is نحن لما نقول renal impairment can lead to high troponin which is steady, assuming that the renal impairment status is also steady. ولكن if you have an acute kidney injury and metabolic derangement that is so dynamic, troponin level is also going to be dynamic. Okay? Yeah? Dynamism of troponin follows the dynamism of the metabolic derangement. ولذلك حتى even if it is rising that much, does not mean ischemia, and it's more in the context of the acute renal injury. Okay? Along with the rising ProPNB. Okay? Even if we do echo, like that patient who had 6,500 level of ProPNB and his LVRV function were normal. This is just because of renal failure. Okay. Type. This ECG is of a patient who presented with compressive chest pain. Which of the following is true? The degree of ST elevation is not prognostic. Coronary angiogram will most likely reveal occluded RCA. Echo will most likely be normal. Normal troponin will rule out STEMI or acute MI. Thrombotic occlusion of the proximal LAD is revealed in the coronary angiogram.
E.
D?
E.
E. Good. E. Yes. Here what we have is an extensive anterior wall MI involving all the precordial leads and the lateral leads. Okay. So, and لاحظ إنه ال ST segment elevation, the degree of ST segment elevation is prognostic as the extent of the, so what is prognostic is the degree and extent of ST elevation. The higher it is, the more prognostic, okay? It's not only the extent. Therefore, this statement is wrong. And of course, troponin normally might be normal. لأنه dynamics of troponin to be squeezed out of the myocardium, it takes time, okay? Especially أنه it is due to the disruption of sacroiliac proteins. So it takes time in the process of necrosis. That's why the initial samples might be negative. Well, that will not ever rules out MI, okay? And echo will most likely be normal. Echo will most likely be normal.
Unlikely will be
Unlikely.
unlikely.
Yani there is no chance of an echo to be normal for this ECG. Okay, we will take the last one. This abnormality can be associated with all except. You see this one here?
There is thinning out of the myocardium with apical hypokinesia.
Very good.
So normal coronary will be the option.
اوكي لكن لاحظي هنا قال the abnormality can be associated with all except. طبعا all except fortunately will no longer be in the exam لأن it's confusing. لكن just for the sake of working the MCQs here out we just put it. Severe MR. Can severe MR be present here?
Yes.
Yes, it can present. LVO tube obstruction. Can it be a complication here?
LVOT.
Yes.
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 Apical
Yes.
thrombus. Yes. Apical
Yes.
thrombus. Can
Yes.
it be a complication? Yes.
Yes.
Normal coronaries.
Yes.
Unlikely.
Yeah.
Toxubo.
Yes, exactly. Severe AR. Can it be a complication of
No.
this condition? No.
No,
So
no.
this is the right
No.
answer. Yeah. Severe AR is not associated with this one here. Now, this one is stress induced ولكن ال MI برضو مرات it looks like that, so we need a scenario. ولكن هو he's pointing towards stress induced cardiomyopathy. أنا طبعا I abbreviated the scenario. It was long. It was clearly showing stress induced cardiomyopathy. Okay, لأنه we really have to have a clinical scenario and all of that. And but I want to remind you that the mechanical complication of an echo that looks like this إذا كان هو MI ممكن يحصل لك papillary muscle rupture صح؟ ممكن يحصل لك VSR صح؟ ممكن يحصل لك rupture free wall rupture تمام؟ ممكن يحصل لك LVOT obstruction. LVOT obstruction is considered one of the mechanical complication of MI and one of the mechanical complication of stress-induced cardiomyopathy which looks like MI. ليه؟ لأنه لما يكون عندك الهارت بقى two segments, one base which is hypercontractile and mid to apex which is hypokinetic, هيحصل pressure gradient that leads to venturi effect of the anterior leaflet. It flies into the LVOT, occlude the LVOT and leads to LVOT obstruction. Okay, so remember in one of the mechanical complication of MI is LVOT obstruction, or of STEMI or of stress-induced cardiomyopathy is LVOT obstruction. Okay. طيب, we are going to stop here. أنا طبعا I believe in 1 hour session. Okay, no more than that. And we are gonna maybe do another 1 hour tomorrow. Okay, I will contact you في الجروب على التايم وهكذا. وزي ما انتوا قلتوا you want us to finish up with all the MCQs صحيح؟ مش كده يا شباب؟